imagine living your entire life with these things happening and saying, you know what, I can deal with this, it doesn't bother me, then I would say kind of wait. Does that make sense?
Yeah.
Now, one thing I would say that we have to do that potentially changes this whole discussion is a spine MRI. So when you, I don't know if when you're reading about Chiari, there's something else called a syrinx, which not everyone with a Chiari has, but it's the Chiari causes changes in spinal fluid flow at the base of your skull. And because of that, you get fluid in your spine. If you get that fluid in your spine and it's expanding your spinal cord, then we typically recommend treating even if the symptoms aren't that bad. Now, for patients who I have this visit and they're, even if you were like, you know what, we don't even have to talk about it, we want to do this, I still get a spine MRI because we want to know if that's something we need to follow. But in people who kind of are on the fence, it also is something where if you see that, it makes a decision easier because it pushes to say, you know what, because the risk of symptoms from a syrinx developing, I think, is higher than the risk of developing new symptoms from Chiari in some ways, because the spinal cord is a smaller space, so things getting stretched out can be a little bit more.
And what is the surgery like and the recovery time like?
Okay, so this is where there is some variation. I'm going to bring your picture back up. There's Chiari, and how you do it is a little bit of a spectrum in the sense of how much you do affects we don't need to do that, the likelihood of success, but also the risk of the procedure. So you can do, at its most basic level, you can do what we call a bone-only Chiari, or posterior fossa decompression, by itself. And all that is removing bone at the base of the skull in C1. And honestly, looking at your film here, I think your C1 looks small to me. So here's the front of C1. There should be kind of bone here, but it looks like you don't have a huge back of C1 there. So there may be a little bit of a bony defect there, which in the big picture doesn't affect things that much. And you can see also the base of the skull's a little flat here. And that's just kind of affecting the anatomy and why this area is a little bit tighter here. You can see C2 is here, and so the tonsil comes close to that. So you can just come and remove bone, and I'm pointing on the wrong one, sorry. This is kind of flat here. I'm pointing on the screen that shows yours, not the one where you can see the arrow. And then, like I was saying, I'm not seeing much bone here. This is the front of C1, so you should see it there. And then this is the bone at C2, which the tonsils come below. So you can just remove bone in this area and some soft tissue. It's a fairly low-risk procedure. But there's a risk of scarring, and even if we make the symptoms better, that they may come back. So it's kind of low risk, but the additional risk of it is that it's not enough and you have to go back and do more again later. The next additional step is that you open the dura, which is the covering of the brain, and sew a graft or a patch in. And the idea is that you're making additional space by doing that. So the dura, which is the covering here, may still restrict things. So by opening that, you're making more space. Sometimes if you're there, if this still really looks tight, we'll even do things to shrink the tonsils a little bit. to try to help that disproportion a little bit. So because you can only make the space so big, you can also make the cerebellum a little bit smaller. And we don't think that there are significant effects from that. The recovery is a little bit longer and harder if you open the dura than if you don't, obviously, because you're doing more. The additional risks relate mainly to the spinal fluid and the fact that you're opening up the spinal fluid to the outside world. There's a small risk of spinal fluid leak. Typically, if you don't have elevated pressure, the risk of that is low, and I think the likelihood that she has elevated pressure is going to be low. The main thing is something we call chemical meningitis. The reason why we use the word chemical or aseptic is it's not like the stuff you hear about on the news with bacteria. Meningitis just means inflammation of the meninges, and that dura is part of the meninges, which is just the covering of your brain. And so even your own blood in your spinal fluid can cause some inflammation. So you feel like you have meningitis, but it's not infectious, so the treatment is just anti-inflammatory medication. So we give steroids, and that makes people feel better. Typically, if you don't open the dura, then people are fully cleared to do whatever they want, typically at about 6 weeks. If you do, then I tend to restrict a little bit longer because we want that graft to heal. So strenuous activity, we tend to say to avoid for about 3 months after. Now, that being said, most people are back in school within 2 weeks. And so, it's always the balance. I have patients that I've had some people who say, all right, can this wait till summer so I don't miss school? And I have other parents who are like, can we do this now so they can have a fun summer and not have to avoid straining?
Yes.
So, I mean, that's kind of a choice du jour. But it really is like, I think one of those things, everybody's a little bit different. It's a lot of muscle back here, so it does hurt to do the surgery. And that's the main thing that limits people in terms of, when they feel up to going back to school, etc. Because you can do all those things without straining. Usually in the hospital, it's somewhere between 2 to 5 days. I would say my average length of stay after this surgery is probably about 2.5 days, meaning half the people leave on post-op day 2, half of them leave on post-op day 3. More likely to leave on post-op day 2 if you don't open the dura. Potentially a little bit more likely to leave. So I would say it's probably like, average is probably like 2.1 if we don't open the dura, and like 2.7 if we do, meaning more likely to leave on day 2 if you don't, more likely to leave on day 3 if you do, but some still. I had somebody from upstate New York who I did on Monday who left on Wednesday. So I may go to a hotel because she lives from so far away before she goes home. Obviously you guys are closer, so so she's allowed to go home tomorrow. I like them to wait just to make sure there's no issues short term before they leave. But it is the type of thing that in the long term, I have certain things that I don't like taking care of patients from a long distance because they need constant care. With the Chiari, it's one of those things you treat it and it's treated. So I operated on a patient recently from Oregon related to Chiari because it's something that once you deal with it, yeah, there are visits, but it tends not necessarily to be a long-term issue once you kind of deal with it.
So just to go back to earlier in the conversation, you were saying that normally you would get the pain in the back of her head. Is there a reason why she's getting it in the middle of her forehead? It's just
No, I mean,
just
it's one
how
of
it
those
is.
things